Hey, good afternoon, everybody. Thank you so much for joining us for CCF Live. My name is Tom Augustine, and I am one of the hepatobiliary surgeons at the Cleveland Clinic. We have a great panel for you today, and I'm going to just ask everyone to just turn their cameras on. So we have, first of all, Dr. Rob Simon. Rob, if you want to just turn your camera on. Rob is one of our HPB staff, and he's been with us for over 5 years at this point. I see Dr. Walsh has joined in. I'll go on to Dr. Nafuji. Dr. Nafuji is a surgical oncologist by training. He's been with us for over 2 years. And again, we'll be talking about biliary access in patients who have CBD stones. Then we have Dr. Katie Stackhouse. Katie, if you want to turn your camera on. Katie is one of our HPB staff who again has a pretty broad range of practice going from livers to pancreas to bile duct. She is going to talk to us today about Meritze syndrome. And then I think we still are waiting for Dr. Naples to join us, who will be leading us through some case discussions. My name is Tom Augustine. I have been with the clinic now for about 10 years. And again, my practice is HPB surgery. Thank you again so much for joining us from all over the world. Give us just a couple of seconds. I'm pretty sure that Dr. Walsh should be able to take over pretty soon.
How about right now?
There you are.
Welcome, everybody. Thanks, Tom, for the intro. There are over 700 providers on this webinar this evening, which will be very exciting in 90 countries. I really want to thank our sponsors, which include Cook Medical, Janssen Biotech, Medtronic, and Olympus. We'd like to get into the presentations. I would encourage all the members out there who are listening to give us questions in the chat. I'll sort of also entertain questions after each talk, and then there will be cases. I think Tom's gave one of them away already, but let's get going. This is a very common topic, I think, of challenging cases that we all have as general surgeons in biliary tract disease. So hopefully our panel here can help us out. So Sam, you want to kick us off?
Yeah, for sure. Well, good evening, everyone from Cleveland. I guess also good morning for some of our audience all over the world. Thank you, Dr. Walsh, for having me on this webinar. So I'm going to be talking today about challenging choledocholithiasis, and I'm going to try to convince you that from our perspective that transcystic biliary endoscopy is actually better than ERCP in handling those stones. So about 15% of patients with gallstones eventually have concomitant choledocholithiasis that is either discovered preoperatively on imaging or intraoperatively on cholangiogram. Choledocholithiasis as a problem on its own must be treated and cleared because it always puts a patient at risk of cholangitis and pancreatitis, both of which can be life-changing and devastating. The options to tackle the choledocholithiasis, the minimally invasive options that we know of today are either ERCP, which is usually done by our GI colleagues, or laparoscopic bile duct exploration. And usually when we compare these two approaches, we look at these certain metrics to tell which one is better. Usually it's the efficacy in removing the common bile duct stones, the associated morbidity, the complications that come with each one of them, the hospitalization and the cost. And there is also a factor that changes from institution to institution, which is the logistics of offering these procedures to the patients, depending on the availability of surgeons' expertise and the availability of the endoscopy techniques. The studies that compare these two approaches, if you look at the literature, I'm not going to bore you much with the body of literature out there, but it spans for over 20 to 25 years, with the earliest trial being in 1998. The problem is that both the ERCP and the laparoscopic techniques have evolved during this period. So this is why you see a lot of discrepancy and fluctuation in the results, favoring one over the other, depending on the trial, where it has been done, the logistics in that institution, and the availability of the expertise. But the general trends of all the trials that you can see in the literature is that there is a trend toward ERCP being more effective in clearing common bile duct stones. The ERCP but also is associated with higher rates of pancreatitis and higher rates of bleeding from the sphincterotomy. The laparoscopic bile duct exploration is associated with high rates of bile leak, especially when it's done transductal or using a choledochotomy incision. But it's associated with, in general, the shorter length of hospitalization. And that comes from the availability of the on-table ERCP during the emergent lab colis. Depends on the institution and on the endoscopist. Most endoscopists, especially for the ones we deal with here, they usually like to scope patients either in a lateral decubitus or a prone position, which is a little bit prohibitive during an emergent lab coli. Also, there's the physical availability of the endoscopist and the willingness to do it on table. That's what usually leads to a longer hospitalization if you do it in a staged approach. Nonetheless, this is a meta-analysis that summarizes all of these trials. I'm going to give you a quick table to show you where they've been done and what they included. Over 2,000 patients were included in the pool. This is a quick table for a summary for the review of these trials, the metrics they looked at. I'm going to go quickly through them just to show you the bottom line, which is the forest plot that shows eventually that from the technical success standpoint, and they define technical success as achieving the goal, the intended goal of the procedure, is not different between ERCP and laparoscopic exploration. The stone clearance also actually turned out not to be very significantly different. And in terms of complication, there is a little bit of a shift toward the ERCP, but it did not turn out to be significant. However, in the final table of the specific morbidity, that's what I want to focus on, is that you can see that there is a significantly higher rate of complications, biliary complications related to the ERCP in terms of pancreatitis, cholangitis, and hemorrhage, whereas the second complication here, which is the bile leak, is the only one that is higher in the laparoscopic exploration. So what we can conclude from this table is that if we can mitigate this risk of bile leak, laparoscopic bile duct exploration in general actually has better outcomes than the ERCP. Now, recently, we know that we have now updated tools to perform the laparoscopic bile duct exploration. Now, the new tool is doing the Transcystic approach, which can be either fluoroscopic guided, fluoroscopy guided, where the tools are we use glucagon to dilate the sphincter or to relax the sphincter, balloon sphincteroplasty, balloon and or basket stone retrieval. This is all over, can be done. All the techniques are mostly adapted from endovascular surgery, where we can pass the instruments over a wire and interrogate the cystic duct and the bile duct down to the sphincter. The other technique is under direct visualization using the endoscopy guidance. We have two choledocoscopes usually available. The most commonly used one is the 2.7 millimeter, which can be passed through a 5 millimeter scope. There's also a larger one, 5 millimeter, that needs at least a 10 millimeter laparoscopy port. We can dilate the bile duct using 8 French balloons and then secure it with a sheath for multiple passages. We can use baskets, balloons, EHL, and laser ablation. Technically the same instruments that our GI colleagues would use with an ERCP. Just a quick gram to show that during laparoscopy, those are at least my setup for the ports. I use 3 5 ports and a 112, and if I do a transcystic exploration, I add an additional 5. With the belly inflated, it will be right at the lower, at the edge of the rib cage, as high as possible and as lateral as possible, which gives us like a kind of a straight trajectory into the cystic duct for cannulation and interrogation. The other technique, which was mostly adopted in the studies that we saw, which probably led to the higher rate of the bile leak, is the transductal approach, which requires a choledochotomy incision, followed by either a primary closure of the duct or a closure over a T-tube. And again, if you look into the detail of the literature that I just showed, actually most of the leaks were related to a T-tube management. So now we're going to compare the transcystic to the transductal approach. And this is one of the larger studies that I found comparing 174 transcystic versus 240 transductal. So over 400 patients in the studies. They found that stone clearance, conversion to open, and mortality were similar. However, any minor, major, and overall morbidity were significantly higher in the transductal. Specifically, if you look at the bile leak, it decreased from about 6% to 1% in the transcystic approach, and the pancreatitis from 7% to 0.6, less than 1% in the transcystic approach. Also, similarly, as a systematic review of the literature, compared both techniques and showed, again, the outcomes that we expected, which is that in transcystic approach, there is a lower bile leak rate than the transductal approach. And finally, of course, we always look for a meta-analysis to summarize everything we know. So this is a nice summary of all the trials in this arena. 18 trials, 2,700 patients. This is a quick table for the review in case we can share the slides at the end of the presentation. But this is the bottom line, is we see that for the transcystic approach, there is a tendency toward having a little bit of a higher stone clearance, but did not reach statistical significance. No difference in conversion to other procedures, whether that being open procedure or actually ERCP. The overall morbidity, it was kind of a trend toward higher morbidity with the transductal, also kind of on the verge of significance. But when you look at biliary morbidity, which is specifically pancreatitis and bile leak, the transcystic approach was significantly superior to the transductal approach. These are some other metrics they looked at, is that the operative time is longer also in the transductal approach, length of hospitalization was longer, the cost was not very different, and blood loss was not different. So this is just, I wanted to kind of finish my slides with a case that I had a few weeks ago. This is a patient who was transferred from another hospital. They were attempted a laparoscopic cholecystectomy. The gallbladder was fused to they said it was fused to the bile duct. So they were only able to mobilize the fundus, and they put a catheter, they shot a cholangiogram, and that's the view they saw, stacked stones into the cystic duct all the way down into the ampulla. So they closed, they put a drain, and they transferred the patient. That was a Monday evening case. I received the patient on Tuesday. I took him to the OR on Wednesday. And with a scope, I was able to go through the cystic duct, cleared all the stones. There was an impacted stone at the ampulla that I was able to retrieve with a basket over the scope. And that's the completion cholangiogram. The bile duct is clear. The patient was home by Friday. So the conclusion of these few slides that I showed was that choledocholithiasis, even when asymptomatic, must be treated and addressed. Minimally invasive available options are ERCP and laparoscopic bile duct exploration, whether that being transcystic or transductal. Both the ERCP and LBDE, they have equivalent technical success, but there is a higher bile leak rate in the bile duct exploration, but we have higher cholangitis, pancreatitis, and bleeding rates with the ERCP. However, when we resort to a transcystic approach, we can mitigate the risk of that bile leak that is usually associated with the transductal or the choledochotomy approach. Eventually, what I would like to close with is that both ERCP and the laparoscopic bile duct exploration, they both have logistic constraints. And mostly it's up to the surgeon who's doing the operation, their expertise and their comfort in doing those procedures. On the other hand, it's the availability of the endoscopy, whether that being on table or in a staged fashion, the procedural positioning, all that will come into play. There is no right and wrong, but when the expertise is available, we believe that transcystic bile duct exploration does give the patient better outcome in terms of hospitalization, shorter disability days, and going home sooner with less complications. And with that, I would like to close my presentation, and I'm happy to take any questions, whether that now or a little bit later, depending on what Dr. Walsh says.
Let's do a couple questions. There's one in the chat, but let me ask you, if someone's getting started in this, who do you think are the best candidates to be doing this on a transcystic approach so they get a certain comfort level? And what choledocoscope, do you think it matters exactly what type of choledocoscope you use?
So I think the best candidates are usually the elective patients that we know about their choledocholithiasis on preoperative imaging, and they're not acutely obstructed, meaning their bilirubin is normal, they're not jaundiced. So you can plan during the lab chole that you will attempt to pass a scope and do a bile duct exploration. I would always recommend, eventually when I started with this, Rob helped me a lot. I would always ask for senior help if somebody is available. The learning curve is not that long, but it has to be done right a few times to understand the technical difficulties of passing a scope, maneuvering it in laparoscopy, where there's a lot of looping inside the patient's abdomen. So definitely elective case and senior help available would be probably the optimal case to start with that. The scope that I use is usually the 2.7 millimeter, and it's just because it usually fits the size of a duct that has seen stones before. Usually they're dilated up to 3-4 millimeters, and it's easy to pass that scope because we have to interrogate some of the valves, especially if you do the cystic duct, the choledochotomy a little bit high on the cystic duct. There's going to be a couple of valves that we have to go through. I always favor that. And recently I've been passing a wire dilating with a balloon and leaving a sheath in the cystic duct for multiple passages so I don't struggle with the free intubation every time.
If you have to do a choledochotomy and you can plan that in advance, do you see any advantage to doing those cases robotically?
Yes, so because I think that suturing the bile duct, usually open the bile duct longitudinally, clear the stones, and I prefer primary closure and leaving an external drain next to the bile duct, especially, of course, but we have to assess the quality of the bile duct. It has to be, it's usually thickened and enlarged because of the chronic obstruction. But yes, I do see a little bit of advantage in the robot because of the endorist that we have with the robot. It makes the suturing, handling smaller needles a little bit better than laparoscopy. That's at least in my hands. My training is a little bit biased toward the robot over laparoscopy.
So we have a great question in the chat, and I would remind people to keep it coming. What do you think, where do you think the role of an open common bile duct exploration fits into this paradigm?
Yeah, so the the point of open versus laparoscopy is just a matter of looking at the metrics and patient hospitalization. I think in the early cases, for the surgeon's comfort, doing it open, there's nothing wrong with doing those open. Like for example, this patient, when he came to me on post-op day 2, I took him for a planned open exploration because of the description that I received from the previous op note. I didn't want to cause any morbidity from bile duct injury or vascular injury. So I took them straight open and they still left the hospital in 2 days. Uh, I think focusing on the complications that come with the procedure is more important than focusing on what kind of incision and how minimally invasive it is. So I think they're equivalent in terms of biliary specific morbidity.
Yeah, I think it's interesting. I think people that comfort level certainly is less in the laparoscopic era with doing an open. But there might be a good indication, and that's what Dr. Naples is going to talk to us about. So Dr. Naples is currently an HPB fellow getting expertly trained, I guess, at the Cleveland Clinic, who's going to join us on staff, and he's going to talk to us about something that we don't always think about. That's why we thought it would be good to talk about it, and those are primary biliary stones. So, Rob, the floor is yours.
All right, let me figure out how to share.
Do you mind if I answer a question, Dr. Walsh, from the chat? I think there was a question about T-tube placement.
Oh, okay, I missed it. Go ahead.
So I am actually a huge fan of primary closure of the bile duct and not leaving a T-tube. T-tube, I think it was in the era when there was not advanced endoscopy and ERCP, and this is to prevent the subsequent bile duct stricture. In this day and age, when we have such advanced endoscopy and so many options for stenting the bile duct, I would say that I personally err away from placing a T-tube. I favor primary closure and external drain, which makes the post-operative management much easier.
Yeah, and there are randomized trials comparing the two, and primary closure is better. The only time I might not is if you have limited access to the bile duct. Let's say, and Rob's going to talk about this later, a post-bypass patient, or you're somehow unsure that you might have residual stones and you needed direct access to the duct later. Rob.
Yes.
Thanks for seeing that question, Sam.
Everyone can see my screen.
Yes.
Okay. So I'm going to talk about primary biliary stones and the operative options. So just in terms of what are primary biliary stones, so these are stones that originate in the bile duct. The composition is mostly brown pigment bilirubin, and it's formed from infected bile rather than cholesterol, which is seen in gallstone disease and secondary biliary stones. And then primary biliary stones are associated with stasis. So it could be due to strictures or some other form of biliary obstruction. And in terms of the goals for surgery for primary biliary stones, there's two of them. So one is clearance of the duct, so to remove all the stones. And the second goal is adequate biliary drainage. So you want to address that biliary stasis. So the options for clearance of the duct there's two of them. So you can do it endoscopically, ERCP, sphincterotomy. They can do lithotripsy sometimes as well. And then there's CBD exploration, which is operative. That could be either transcystic or transductal. ERCP has about typically a 95% rate success of clearance of the duct based on the stone size and the patient's anatomy. And about 25% of patients will recur with stones after an ERCP sphincterotomy. And this was a study from 2003. It was a single surgeon experience, and he came up with factors that helped determine which CBD exploration was the best in terms of transcystic or transductal. So just to point out a couple, the stone size was important. So stones greater than 6 millimeters, you can't do a transcystic approach. And then if the cystic duct is too small as well, he said less than 4 millimeters, a transcystic approach is not typically feasible. And then you also want to look at the diameter of the common bile duct. So the smaller it is, the less likely a transductal approach would work. The one thing that's probably not on here is how long the cystic duct is and whether it's tortuous or not, as well, if you're going to, use a choledocoscope. And then in terms of the surgical options for biliary drainage, there's 3 of them. There's a transduodenal sphincteroplasty, a choledochoduodenostomy, and a Roux-y choledochojejunostomy. The one thing obviously not on here, the one option also for biliary drainage is a sphincterotomy, but I'll just be going over the surgical options here. So this is a transduodenal sphincteroplasty. So the indications are primary biliary stones, if there's an impacted ampullary stone, and then stenosis of the sphincter of Oddi. Some of the disadvantages of it are you could get some syndrome, and then it's typically not performed as much today. So it's a more challenging case and more complex, I would say. And it's fallen out of favor due to the advent of endoscopic sphincterotomy. On the right here, this is kind of how you do the transduodenal sphincteroplasty. And then this was a patient, 62-year-old, had a history of Roux-y gastric bypass, was referred to us for choledocholithiasis. She actually underwent a laparoscopic transgastric ERCP, and unfortunately the endoscopic approach was unable to clear the duct. So on the left side, you can see stones and the stones in the distal CBD, and the duodenum is not filling. So the patient actually was open and got a transduodenal sphincteroplasty, and the cholangiogram here on the right-hand side is after the transduodenal sphincteroplasty, and we can see all the stones are gone, and there's good drainage into the duodenum. And then this is a choledochoduodenostomy is another option. So it's indicated for primary biliary stones and also for patients that need biliary drainage, such as a CBD injury. The disadvantages of this are sump syndrome, and then you could get bile reflux as well with this. The surgical technique is you can either do an end to side or a side to side. It's really surgeon preference. And then the Roux-y choledochojejunostomy, the indications are the same as the choledochoduodenostomy with primary biliary stones and need for biliary drainage. The disadvantages for this is you have difficult access to the biliary tree endoscopically if you do an end to side after this, and an additional anastomosis is needed with the jejunostomy. Again, this can be performed end to side or side to side. And then just some patient factors to consider when you're deciding on a biliary drainage procedure. One is the anatomy. Do they have Roux-y anatomy, a gastric bypass, a Bile-Roth 2? Those patients are less likely to have some syndrome, but have difficult access to the biliary tree in the future. And also the addition of a Roux-y HJ could be more challenging for this patient. And then you want to look at the CBD size. The smaller the CBD, the more challenging the anastomosis will be. Bilioenteric anastomosis, so maybe another option would be better. And then if they've had a previous sphincterotomy, maybe a bilioenteric anastomosis would be a better option. And then in terms of age, you know, the younger patients in HJ is less likely to have some syndrome and complications. So maybe that would be a better option in younger patients. Older patients, if the duodenum is closer, it's right there, it's a little bit easier. That could be a good option for older patients. And then just to go over some scans. So this is an 80-year-old female who came to us, referred to us with choledocholithiasis. And this is her CT scan. So this is, she's got biliary dilation and she's got these big common bile duct stones, and this is her gallbladder. So this is a patient that was taken to the operating room. She had a cholecystectomy, a CBD exploration, and then she had a side-to-side choledocho duodenostomy performed. And then this is another 72-year-old male who was referred to us for choledocholithiasis. And this is his CT scan on the right. You see these little gallstones, and he has gallstones in his CBD. And this is his intraoperative cholangiogram. And the one thing to note about this is these are all the stones here. These stones are bigger than the cystic duct. So this patient probably has some problem, even though his gallbladder is in, he probably has some primary biliary stones and biliary stasis that could be considered for a biliary bypass. And then just the take-home points, primary biliary stones are due to biliary stasis, indicating the need for better drainage. Stones in the CBD that are larger than the cystic duct should raise suspicion for primary biliary stones. And surgical management should take patient factors into consideration and be individualized on a case-by-case basis. And
Okay, thanks, Rob. Sam, don't go anywhere because there's another question for you on the chat box. But I guess the important things that I would just highlight from Rob's talk is if you have a really small cystic duct and you have a big common bile duct with stones, especially multiple faceted stones, those are probably primary stones. Now, many people will get an endoscopic treatment. I understand that because a lot of these people are older, but once you do a sphincterotomy and they get recurrent stone disease, they're at a risk for cholangitis. And if you do a biliary bypass, you have to make sure you clear out those distal stones. Otherwise, you'll still get cholangitis if they have residual stones. So you have to get them all out. Make sure you do a completion cholangiogram. So Sam, would you recommend a transcystic duct common bile duct exploration for a patient with previous history of jaundice and no preoperative imaging during the cholecystectomy?
I'm sorry, the patient is jaundiced?
Had a history of it, prior history of jaundice. So they had jaundice, they have gallstones, you're doing a lap chole. Could they still be a candidate for transcystic?
I would say yes. Of course, we start with the cholangiogram, make sure that there's not a distal malignant appearing obstruction first. I mean, usually if the malignant jaundice does not resolve, the benign choledocholithiasis jaundice usually resolves if they pass the stone. But I don't think it's a contraindication to pass and take a look. I usually scope down to the ampulla, and I actually pass it. The end point of my scope is to see duodenal mucosa, the brush border, before I pull back. And I don't think a history of previous jaundice would prohibit that.
Yeah, I would agree with that. And it also speaks to what we didn't do as a separate talk, just who needs imaging or not. We tend to not do a lot of imaging because you can take the gallbladder out and shoot your own cholangiogram, and that's the imaging that you need. A lot of people waste time and money on MRCPs. Okay, so a real challenge is a bile duct injury and how to manage them. And one of the issues, there are many issues, but one of them is if the patient needs surgical repair, when is the best time to do it if you have an injury? And I can think of no better person to talk about it than Tom's Augustine. Tom's?
Dr. Justin, you are muted and your screen is back to
All right.
not
Let
full
me,
screen.
Swap screens.
yeah, let me just share my screen again. Sorry about that. Share. And you can hear me still, right? Great, thank you. Dr. Walsh, it's such a distinct pleasure, and thank you for having me talk about this. This is obviously an issue that's near and dear to a lot of surgeons out there, whether that be a general surgeon or a specialist surgeon. So with that, iatrogenic bile duct injury. So I'm going to focus on basically timing of repair. I'm not going to go into details regarding how to repair those injuries. That's obviously a pretty long talk. But iatrogenic bile duct injuries are devastating. They're devastating for most commonly the general surgeon who has them. And despite papers, white papers, literature about this, we continue to see that 0.2 to 0.6%, so 1 out of 300, 1 out of 1,000 patients will continue to have a bile duct injury. Well, it's obviously really important to recognize bile duct injuries when they happen, but it's more important to make sure that we follow all kinds of safe techniques when we do cholecystectomies. We really want to emphasize critical view. We want to really liberally use intraoperative cholangiograms. And again, I think we can go back and forth about it, but I think that general surgeons and surgeons who are facile with intraoperative cholangiograms are also usually more facile at recognizing injuries and also more familiar with biliary anatomy. Convert to open if you need to, and use subtotal cholecystectomies. Now, there's an increasing growing literature of subtotal cholecystectomies. I don't think it's controversial that they will avoid bile duct injuries, and then any day a subtotal is better than a bile duct injuries. But despite all of that, we still continue to have BDI, and one of us may have it. So so let's talk about how do you classify bile duct injuries, and I'll talk about the timing based on some of these. Now, for most part, type A, this is a Strasbourg classification. We follow this at the clinic, and for most part, Strasbourg A and Strasbourg B generally do not end up coming to a surgeon. So Strasbourg A generally can be managed endoscopically with a biliary stent, and Strasbourg B may remain quite asymptomatic. So that's actually a transection and clipping of the right posterior bile duct. So because the bile leak is controlled from the clip, these patients tend not to get into trouble, and they may show up sometimes years later. Now, class C to class E are all surgical. So just quickly, type C is where you have a right posterior duct transection and there is a leak from that transection. Now, why do we always talk about a right posterior duct? Because you have anomalous right posterior ducts in certain number of cholecystectomies. Sometimes these ducts are going into the cystic duct, so you may misidentify a right posterior as a cystic duct, and that I have seen, or you may cut the cystic duct below where the right posterior duct is coming in, and then when you take the gallbladder off, you cut the right posterior with it. So right posterior ducts, be careful with that anatomy. It is something that I have seen, and I've also seen the downsides of it. A Strasbourg D is where you have a partial transection of the common bile duct. Now these may not need to be managed surgically, but if you get called into the operating room with one of these, you will end up managing it surgically. Class E or type E transactions are always managed surgically. These are things that are hard to fix without an operation. I'll show you a variation of that. So timing of surgical repair. So everything about surgical repair is based off of the timing of the recognition of the bile duct injury. So the best case scenario is that the surgeon who is doing the cholecystectomy even has a faint suspicion that there may be a bile duct injury. That's all you need to have. You don't need to know that there's a bile duct injury. You don't need to prove that there's a bile duct injury. All you need to do is just recognize the possibility of a bile duct injury. So these patients where there is some suspicion that there was a bile duct injury or there is a suspicion of a bile duct injury, I think those cases should be immediately escalated to either in-house expertise or transferred to a higher center where expertise may be available. Now, if you're comfortable doing a cholangiogram to prove that, then that's fine. But obviously, remember, you don't want to make the injury worse by trying to do a cholangiogram in a tough case. Always you leave a drain in place. And obviously, if you have in-house expertise, that is just the most ideal. Intraoperative recognition is the key to making sure that these patients have the best short and long-term outcomes. So this is, for example, a patient that underwent a cholangiogram during a cholecystectomy. The images on the left side is showing that intraoperative cholangiogram. The patient was transferred. Actually was transferred from operating room to operating room. We basically took him from the OR where he had the chole to the OR where he had the repair, and then he underwent an HA and has had excellent outcomes. You know, these patients may not ever really feel the consequences of a bile duct injury. I can't stress to you how important it is to recognize that there is a possibility of a bile duct injury. Now, this is very close to what happens if so I'm calling these immediate, but these could just as much be intraoperative recognition. The difference between what I'm calling intraoperative to immediate is that that let's just say this patient is in a center that's far away from subspecialty expertise. The surgeon has recognized that there's an injury. They leave a drain, and then the patient gets transferred out. Now that is really the ideal situation. Now, immediate recognition, but without a drain in place is a completely different scenario. So the patient had a bile duct injury. They present very quickly after the cholecystectomy, usually within days. They're admitted with usually bile peritonitis, and those patients are treated as though they presented late with sepsis. And I'll talk a little bit about that in my next slide. So again, immediate recognition with a drain behaves very much like an intraoperative recognition. Immediate recognition with no drain, patients end up being septic. Now, this is where, unfortunately, majority of our patients might end up presenting. These are also the most litigated cases. And the reason why is because these patients, although most of these patients who are recognized late postoperatively have had the cholecystectomy and did not have a drain placed in the operating room. Almost universally, every one of these patients will present with sepsis. The most important principles are to control sepsis, and very often these patients will need a diagnostic laparoscopy to wash their abdomen out. They're obviously started on antibiotics. The surgeon who is doing the diagnostic laparoscopy very often cannot recognize where the injury is. They do wide drainage, and after you control the sepsis, you investigate these patients to figure out what their injury is. Start with an MRI. That's a really good test, but you may also be fine starting off with an ERCP. So I think it depends upon what you think based on your review of the operative report. The key thing is that these patients will usually have their injury repaired in a delayed fashion, usually around the 3-month mark when everything is nicely scarred in. It's really important also to get an investigation to make sure there's no damage to the vasculature before you take these patients to the operating room. So this is, again, a patient who had an unsuspected bile duct injury during cholecystectomy. This cholangiogram is from an intraoperative cholangiogram. She had obviously a Strasbourg E, and then an HA was done. This repair was performed approximately 3 months after the cholecystectomy. This patient had come in with septic shock. We did a diagnostic lab washout, all the things that we talked about. Now, you know, in these patients, a PTHC before surgery is very often quite helpful. And I can't stress to you the importance of making sure that you do see the right posterior duct before you take these patients to the operating room, because those ductal injuries may not show up on any other testing. And then there is the patient with the remote presentation. Now, these are patients who may have had the cholecystectomy 2 or 3 years ago, and they are just presenting to you with either some vague symptoms of severe right upper quadrant pain, and then things start to show up, or they may have had an abnormal course after their cholecystectomy. The patients who present with jaundice or cholangitis, obviously, when you get some sort of an imaging, you'll see why they have jaundice. Typically, they will have biliary continuity, right? So the common hepatic duct and the common bile duct are continuous, and that's why they haven't presented earlier with bile leaks or bile peritonitis. Most of the time, or sometimes you can have a stricture of the common bile duct or a common hepatic duct that's been managed endoscopically. Sometimes you may have a right posterior duct that's been clipped, and the patient now has right-sided pain because the right posterior lobe is not very well drained. These patients, the real key thing or the most important thing for these patients is that the management can be quite complex. You have to start with, and this is my preference, obviously there might be experts in the call who might defer in their practices, but MRI with contrast is absolutely key. It's really important to recognize whether there has been any vascular injury or not, and then recognize, can you account for all the bile ducts? Is the right posterior, right anterior, left lateral, left medial, all of those ducts, are they really accounted for? Now, I think a word of a recommendation, if you are dealing with one of these, is do not put a stent prior to the MRI. So do not stent the patient prior to the MRI. The MRI, it's really nice to see the MRI with the dilated ducts. So get the MRI with the contrast first, and then do any invasive procedure that you're planning. Now, this is, again, a case study, a young patient who had a cholecystectomy 2 years prior to seeing me, and she's had these ERCP with bile duct strictures. And even though the endoscopist said that the stricture is somewhat resolved, on endoscopy, the patient continued to have pretty severe right up quadrant abdominal pain. And so I took her to the OR for exploration. I apologize for the quality of this picture. This is just an intraoperative picture. The common hepatic duct is up there. The common bile duct is out there. I had opened the bile duct, and then inside the duct, there were these laparoscopically placed clips. So the patient had I suspect the patient had a class E Strasbourg injury, which was just managed with clips, and then the clips continue to cause her discomfort and pain. This patient underwent an HA with good outcomes. So in conclusion, bile duct injuries persist in the laparoscopic era. Intraoperative recognition is absolutely key to the best short and long-term outcomes. If there's any suspicion, and I can't stress this enough, please leave a drain in the operating room and promptly investigate any unusual symptoms after a cholecystectomy. Patients should be doing fine after cholecystectomies. If they have symptoms, please investigate them and avoid delays at all costs. Thank you so much.
Thanks, Toms. I don't see any questions in the chat yet, but I'll ask you a couple. So do you think, are you using ICG, and do you think that could help prevent bile duct injuries by seeing the anatomy relatively easy? What's your take? What would you recommend to this audience on ICG for bile duct injuries?
I think it's a reasonable tool in a surgeon's toolbox. I think whatever is helpful to see biliary anatomy and visualize it well, and make sure the cholecystectomy is safe. But I would say that there's no substitute for still a critical view. I'm a routine cholangiographer, so I always do cholangiograms, and I don't think that anybody should use an ICG to substitute for all the other safe techniques that we talk about during to keep the cholecystectomy safe. But I think it's a good tool to have an additional step to verify biliary anatomy.
And if you have a patient who presents in the early post-op period, and you're doing a delayed repair, and you have external drainage that's totally diverting the bile as you're waiting, I think you said 3 to 6 months, what do you have to do about electrolytes? If you have that scenario, do you move up the timing if you're completely diverting their bile? What do you think?
Yeah, I think that's a really great question. So, unfortunately, we don't have, as you are obviously aware, being an expert, that there's just no humane way to give them their bile back. All of those techniques are hard to sell to a patient. I wouldn't do it myself too, but here we would use a Gatorade, a sports drink. I don't know what the names might be across the world, but Gatorade and other kinds of sports drinks generally tend to have the electrolytes that the patients would need. Obviously, you try not to have, it can be difficult if the patient has excessive drainage, which can be an issue, but thankfully those cases tend to be quite rare, one-off, and we do our best in those patients where the delayed repair is absolutely essential.
There's a question from the chat. Thanks for that. Are you seeing any duct injuries in patients with gastric bypass, and what options for repair?
Yeah, it's a really great question. I haven't personally seen duct injuries in my practice in a patient with a gastric bypass. Actually, that's not true. I've seen a patient whose duct was clipped and had an atrophic segment that required a liver resection. But I think that you would follow a standard management pathway for patients with a bypass. I suspect that these patients, if they need to be repaired surgically, might end up needing a double bypass, where you take another Roux limb to the bile duct. That's what I would say.
Well, I would say it's if possible, which it often is, it's the perfect time to use the duodenum because the stomach's already bypassed. So
Yeah.
you can use the duodenum. Obviously, you probably aren't going to be doing ERCPs, but PTHC is probably a better approach anyway to define the anatomy after you've done, if you've had the opportunity for an MRCP. But yeah, the duodenum works great in that scenario. Okay, good questions. Good topic, I think. Speaking of gastric bypass, what a lead-in for Dr. Simon, who loves these cases. So this is obviously more and more common, and it can be a challenge. So Rob, fill us in on how we can access the bile duct after a Roux-y gastric bypass.
Awesome. Yeah, that couldn't have been a better segue. All right, so I'm going to talk about accessing the biliary tree after Roux-y gastric bypass. Just a little background. So the 5-year incidence of gallbladder disease in patients who have had a Roux-y gastric bypass is about 15%. Now, most of those are, just related to symptomatic cholelithiasis, but about 1% of those is related to choledocholithiasis. So, per the ASMBS in 2022, about 62,000 people underwent Roux-y gastric bypass surgery. So, even 1% of those is, a significant amount, about 600 people who get choledocholithiasis. So it's rare, but it's actually a pretty significant number because of all the Roux-y gastric bypass patients that are being performed nowadays. I think that number is only going to go up. So pathophysiology, little bit, going to go through this quickly, but the pathophysiology of cholelithiasis from Roux-y gastric bypass is multifactorial, and it kind of involves several interconnected factors. So rapid weight loss, which obviously is the point of gastric bypass surgery, can lead to increased cholesterol saturation in the bile due to changes in the hepatic cholesterol metabolism. And so then this increased cholesterol concentration can predispose them to cholelithiasis. Altered bile composition, again, same thing. The altered enterohepatic circulation can result in increased bile stasis, which promotes gallstone formation as well. And then additionally, the reduced size of the gastric pouch may actually lead to decreased gallbladder emptying, again, further contributing to bile stasis. Now, there's also some hormonal changes that can occur after Roux-y gastric bypass. So it can actually affect the secretion of gut hormones such as cholecystokinin, which regulates gallbladder contraction and bile flow. So the altered levels of CCK involved in gallbladder motility and bile composition, again, may contribute to gallstone formation. And then lastly, dietary factors. So post-surgical dietary changes such as reduced fat intake or alterations in meal frequency and composition can also impact gallbladder function and bile composition, again, potentially predisposing patients to gallstone formation. So, you know, this is the anatomy before and after. So when choledocholithiasis occurs, accessing the ampulla becomes a challenge as the normal anatomy is altered. It's a long path down that Roux limb and back up that BP limb. So, you know, there's 3 different ways to nowadays to access the ampulla. You can go antegrade down the stomach into the Roux limb and then retrograde up the BP limb to try and access the ampulla that way. You can do a transgastric approach to try and access the ampulla in a normal antegrade fashion. And then you can do an edge procedure, which we'll talk about all these options. So first, you know, standard duodenoscope. So just a standard EGD. So, you know, it's the standard ERCP side viewing duodenoscope is honestly not very successful in patients with Roux-y anatomy. So, you know, approximately you have a 140 centimeter Roux limb and a 75 centimeter long, you know, BP limb, you know, average. So that, you know, with the esophagus and everything, that's approximately 275 centimeters that you got to get through. So using a regular scope is challenging and often not successful. It can work in patients with shorter Roux limbs. You know, for patients that are getting gastric surgery and Roux-y gastric jejunostomies for reasons other than gastric bypass and weight loss, sometimes those Roux limbs are a little shorter, and so, you know, a standard side viewing scope can sometimes be successful. So that brings me to balloon enteroscopy. So double balloon enteroscopy, first described in 2001, can be a good option. So a big randomized controlled trial looked at using balloon enteroscopy in Roux-y gastric bypass patients, and they found that the papilla or the biliary anastomosis was reached 89% of the time with a 93% successful cannulation rate. Overall therapeutic success rate was 82%. Now, the caveat being that when they did a subset analysis in patients with long Roux limbs, so basically gastric bypass patients, that therapeutic success rate dropped significantly to 58%. And so, you know, it can be done. I will say the other caveat being that it does require, you know, an advanced endoscopist. And so, you know, not everybody does these. Not every endoscopist feels comfortable doing balloon enteroscopy. And so it might not be available at your hospital. So what are some other options? Well, you can do a laparoscopic or open transgastric approach. So some tips and tricks for this, you know, it's got to be a 15 millimeter port that you place in the stomach. I like to put some tacking sutures on the stomach before I make my gastrotomy to put the port in. That allows me to kind of pull the stomach up and help keep it opposed to the abdominal wall while the endoscopy is being performed. I use a Carter Thomason to bring the tails of those sutures out so that I can put a little tension on that. And then when you're doing the endoscopy, you desufflate the abdomen. Again, that helps keep that abdominal wall opposed to the stomach and helps the endoscopist perform the procedure. In addition, you can use a balloon port. Again, those aren't always readily available, but that can also be very helpful. Getting further away, placing your port further away from the pylorus is better for the endoscopist. It allows them a little bit more natural access and a little bit better of an angle to get through the pylorus and into that duodenum and perform that procedure. When doing the endoscopy, I always find it helps to do CO2. And so you got to ask the endoscopist to make sure that the CO2 is connected. You can also place a clamp across the BP limb to try and limit the amount of bowel distension that happens, but CO2 is very helpful. And then, one of the downsides to laparoscopic or open transgastric approach is that if you require multiple ERCPs. So if they feel that a stent needs to be placed, or they're unable to, for whatever reason, cannulate or get all the stones out, or they want to go back at a different time, leaving a G tube can be helpful so that can allow easier access into the stomach for repeat endoscopies. The other challenging thing is that this procedure is done supine, which normally a lot of ERCPs are done prone, and so the endoscopist may not feel as comfortable doing these, and may take a little bit of a learning curve from their standpoint to access that ampulla successfully. But as long as you're able to get access into the stomach, the success rate is pretty much on par with a normal ERCP. So this is a good option. Lastly, I want to talk about an edge procedure. So an edge procedure, I have to admit, I was very skeptical about this when I first heard about it. But basically, they use a metal opposing or a lumen opposing metal stent to create a fistula between the stomach pouch and the stomach remnant. And then they're able to drive the ERCP camera, antegrade, get to the ampulla, access it, and perform their ERCP. One of the downsides is that it requires multiple endoscopies. They don't want to drive the camera through that stent at the same time that they place the stent. They want to move for that tract to mature to decrease the chances of dislodgement of that stent. And so in patients who are cholangitic, this is not a great option. Either transgastric approach that allows you to do the ERCP right away, or placing a PTC to temporize, having them do the edge as well, and then they can go and access the remnant, usually 7 to 14 days later, to get access. So, there's been 2 really good studies that have really flipped my perspective on this procedure. So the first one, done in 2021, looked at 178 patients, and they showed a technical success rate of 98%, which is fantastic. There were only 4 severe adverse events that were all managed laparoscopically, and 90 patients who were sent for objective testing for a persistent fistula, they only found that 10% were actually identified to have one. So there were some patients who presented and they were having some vague symptoms. They went and got tested for fistulas, and only 9 patients were found to have a fistula. 5 of those went on to be closed endoscopically, and all 5 of those were successful. And then the second study that just came out last year looked at 172 patients. The metal stent was successfully placed in 99.4% of patients. And again, technical success rate of the ERCP was 95%. Endoscopic closure of the fistula was performed in 40% of patients at the time of the procedure, and then 31% developed a persistent fistula in those that were assessed. And again, most of those were able to be, the vast majority of those were able to be closed endoscopically. Now, one of the big reasons that I was so skeptical about this was worrying about weight regain. And this study in 2023 actually did a great job at looking at long-term outcomes. And so most patients gained less than 5 pounds. And for those that gained more than 5 pounds, the median weight gain was still only 12 pounds. So weight regain is actually uncommon. So I think edge procedure has kind of proven that it can be a really effective option in these patients. So just to kind of summarize, there's some options. Standard duodenoscopy, really only for shorter Roux limbs. Balloon enteroscopy, again, can be done in longer Roux limbs in gastric bypass patients, but only has a success rate of less than 60%. transgastric approaches are great, as well as edge procedures. So some takeaways. Choledocholitis is a rare entity in those after Roux-y gastric bypass, but it can be pretty tricky to take care of. Balloon enteroscopy, one of the downsides is that it does require an advanced endoscopist. Transgastric approach is safe and effective. There's multiple studies to kind of prove that. Use a 15 port, put it away from the pylorus, use some CO2, tack that stomach up to the abdominal wall. And then edge is safer than you think, but can't be done in one setting. And then lastly, again, place a PTC to temporize as needed. That's always kind of another option to keep in your back pocket. So thank you very much.
Okay, thanks, Rob. You have a question in the chat. What about, do you think if you do a double balloon endoscopy, a long scope you get there, are there tools to be able to actually do the stone extraction?
Yeah, so for the balloon enteroscopy, there are, again, that's part of why it is difficult to do and why the technical success rate was so low in those patients is because it's a balloon enteroscopy, it's an end viewing scope. And so accessing the ampulla and even seeing it sometimes can be challenging, but it does have the same size working port that ERCP or a side viewing scope has. And so they have the same tools at their disposal. It's just viewing and accessing can be tricky from that angle.
Yeah, I think the therapeutic success, you actually mentioned that it was over 80%.
Right.
So if they get there.
If they get there.
And so my question for you is, with edge, you seem optimistic. So should we ever be doing the laparoscopic assisted transgastric?
Yeah, I think the metal opposing stents are becoming more and more popular, and more advanced endoscopists are using them, especially for, we use them all the time, or our endoscopists use them all the time for necrotizing pancreatitis or big pseudocysts. And so, I think before it was not readily available, and I don't think a lot of people felt comfortable doing it, but I think with this data coming out, I think it's becoming more and more adopted. And so, I do think that transgastric approaches are going to be less and less, but there's still a role for it. I think especially in hospitals that don't have the capabilities. I think there are, I know that one study had a 99.4% rate.
Well, that you can never believe.
Right. And so, there are going to be some patients where you can't access that remnant with a stent. And so, transgastric approaches are going to be
okay. And what about a direct laparoscopic approach to the bile duct? When is that, do you think, a good option in someone who's had a gastric bypass?
I think, again, it kind of just goes back to the prior points that were made. I think those, having, doing a laparoscopic cholecystectomy, and if you can clear the duct transcystically, I think that's, probably best case scenario.
There's a question on, can edge be accomplished in as few as 2 procedures?
It can, yeah. So the first one, they place the stent, that's it. And then, about 7 to 14 days later, they'll take them back and do the ERCP. And then when they're done with that, they take the stent out and they're done.
The same day, take the stent out?
Mhm.
Okay.
And then clip it.
I'm sorry?
And then they often put like a big Avesco clip or something on it.
Yeah, something they hope will work. Okay. Katie, I know the hour is running a little bit late, but I know you presented some cool cases. Do you want to, let's do the first one and see how that goes.
I'll present the one that's on a topic we haven't talked about yet, and that way if we're out of time, it's no big deal. Share my screen. All right. Able to see that okay? Great. So this is just a case presentation. So this is and thank you to Dr. Simon for providing the case. This is a 72-year-old male who presented with abdominal pain and weight loss. He had one visit to the ER, but was for these symptoms, but was being seen at an outside hospital as an outpatient in the elective setting. He had no known past medical history, and his surgical history was significant for an appendectomy and 2 inguinal hernia repairs. So this is a CT scan that he had prior to undergoing an operation. So here you can see this is his gallbladder with the red arrow pointing to it with a very large gallstone. This is further down in his gallbladder, more in the infundibulum, that has a second large stone. Here I just wanted to point out this is the right and left ducts coming in towards the bifurcation, both of which are moderately dilated. And then here I wanted to point out here, I don't know if you can see my mouse, but this is the gallbladder here, and you can follow the bile duct down and you can see that it disappears here, kind of where that red arrow is. The read of this CT scan was read as soft tissue density. That may represent sludge, but could be a possible mass lesion, could not rule out malignancy. He was then taken electively for a laparoscopic converted to open cholecystectomy that was ultimately aborted. According to the operative dictation from the outside hospital, they were unable to safely dissect around the gallbladder and get behind this area of soft tissue that was concerning for malignancy. They were unable to dissect the gallbladder off of the duodenum and ultimately decided for safety reasons to abort the procedure. And so the patient was transferred to Cleveland Clinic for further care. So when the patient arrived to us, an MRI was obtained. Do any of the panelists want to kind of describe what the MRI is showing? Make it a little more interactive?
Shows Mirizzi syndrome.
Sure.
So compression of the bile duct at the left of the bifurcation by likely a stone in the cystic duct or something like that.
Exactly. So here, I just wanted to point out a couple of these are coronal slices. The first one on the left, you can see the bifurcation coming together of the right and left hepatic ducts. You can also obviously see these 2 giant stones in the gallbladder. The second picture, you can see the common hepatic duct coming down, and you can start to see narrowing, and that eventually disappears. And then this third picture is a representative slice of distal to where these stones are compressing. The common bile duct, as it enters the pancreas, is normal.
There isn't a lot of proximal dilatation.
No, there's not a whole lot.
Yeah, interesting.
So this is the operative course of the patient. The procedure was started laparoscopically. The gallbladder was decompressed. There were noted to be extensive inflammatory changes, and given all of these inflammatory changes and concern for a mass, the decision was made to convert to an open subcostal incision. So after that incision was made, the gallbladder was dissected in a top-down fashion. There was a large fistula that was identified between the gallbladder and the common hepatic duct that contained one of these large gallstones. So here in these photos, the common bile duct is encircled with this blue vessel loop and this lower arrow on the left-hand sided photo. And then the upper arrow on the left photo is showing this big open lumen, which is the common hepatic duct that previously contained that stone that had fistulized into the common hepatic duct. And then the picture on the right, again, the common bile duct is encircled with the vessel loop, and the DeBakey is pointing proximally up through the lumen of the common hepatic duct. So next, a cholangiogram was done proximal to the area of the fistula with an aerostat catheter. And this is notable for patent right and left bile ducts and an intact hilum. And then after that, a separate cholangiogram was done distal to the fistula in the common bile duct, and this showed prompt filling of the duodenum with no evidence of defects. So at this point, the proximal common hepatic duct was cut sharply above the level of the fistula. The distal common bile duct was ligated with a silk tie and a clip, and the specimen was passed off. A rulin was brought up anti-colic, and an end-to-side interrupted hand-sewn hepatico-jejunostomy was performed, followed by an end-to-side jejuno-jejunostomy to complete the Roux-y. A drain was placed posterior to the HJ, and then the patient was irrigated and closed. This is the specimen picture, so you can see the gallbladder at the bottom, the very, very large stone, and then this top portion with the DeBakey through it is the fistula and common hepatic duct, with that big hole in the middle being where the stone had eroded through. Postoperative course was very uneventful. The JP was serous sanguinous and removed prior to discharge. Diet was slowly advanced and the patient was discharged on post-op day 5. So I just wanted to take a moment. I'm sorry, that's the wrong presentation.
Mertzi does have a classification system though too. We could.
Sure. So we can talk about that. So Roux-y syndrome is defined as biliary obstruction secondary to compression from large gallstones. It's been reported to occur between 0.3 and 3% of cholecystectomies. And there are 2 types of Roux-y syndrome that are that have been reported. Type 1 is extrinsic compression of the bile duct, and this essentially causes a stricture of the bile duct and narrowing. And then type 2, which is a cholecysto-choledochal fistula, where the stone truly erodes into the bile duct rather than just compressing it from the outside. And some options that are discussed in order to deal with this problem include a partial cholecystectomy, where you open the gallbladder and you can remove these large stones and relieve the external compression. That is potentially an option for a type 1 Roux-y syndrome versus in severe cases such as this one, biliary reconstruction is obviously necessary in order to restore normal biliary drainage. So that's all I have for that case.
What's the pathology? Where is the cancer on that patient?
There was no cancer in that case.
As usual.
I will say, one of the big points about this case, and I want to commend that surgeon, is that, he recognized that he didn't feel comfortable doing that case and he was probably going to get into trouble. And so he stopped, he closed, and he sent him over right away and called me himself. And so I think that
Absolutely the right decision.
is also, a good take home point for that case.
So let me ask the group, if you have a suspected Merizzi's, would you, is that a time that you would do a preoperative stent, have a stent in before you operate or not?
I can take that question to Katie. Why don't you go ahead since you presented the case?
Oh, sure. In one of these cases that I did recently, that was a type 1, I did put a biliary stent in preoperatively, so that way if I got into the bile duct, I would see it and know it, and especially because I was doing it laparoscopically. So I found it to be helpful, and it surely didn't hurt anything to have the stent in place, in my opinion. But I don't know, Dr. Augustin, if you have a different take.
No, I second that. I think having a biliary stent has several advantages. So first of all, I mean, they end up with an ERCP very often because cholangiocarcinoma is on the differential. And the endoscopic imaging with an experienced endoscopist can really help differentiate this from a cholangio. And this was not a subtle case that you presented, but cases can be subtle. And the second is, you don't always need to do an HJ. If you have, stents going up both the right and the left side, and you have a big hole in the bile duct, you can just close it on top of the stent and be done with the case with external drainage. So avoid an HJ. So I would say stenting is absolutely essential.
Yeah, I think this is one of the times that you do want an ERCP in a stent. I think it can, knowing the distance from the bifurcation is helpful. During intra-op is helpful. You can use ultrasound too to identify the stent if you're lost. So I think there are a lot of advantages. So I would think about it if you're in that scenario.
To confirm to the audience, a plastic stent is what we're talking about.
Yes. Yeah, good point. Thank you. Rob, there is one question for you from your talk. What is the risk of gallstones developing after a sleeve gastrectomy versus Roux-y?
It's about the same. It's pretty much the same pathophysiology, and so that risk is pretty equal.
Okay, I don't think we have time for your other case, Katie. Maybe we'll save it for a future episode in the saga of ongoing biliary problems. I hope you have enjoyed this webinar. We do have a series of them, and there will be an update on the lateral pelvic lymph nodes and rectal cancer. That is something that keeps me awake at night, so I probably will be in attendance. So thanks, everybody. I think we had a great panel, and these are certainly common problems that they're good to talk through. Thanks very much.